inviting me to this conference, and I'm delighted that I can share some of the experiences we've had in taking care of children infected with SARS-CoV-2, also named as COVID-19 in children. And mostly I'll review a little bit of what's already been published about children with COVID-19 and touch upon what we've been seeing here in Central New Jersey.
Sunanda, you have to speak up just a little bit.
Oh, okay. Is it better now?
Yes, thank you.
Okay, 1 second. Just give me a second. I need to get this. Okay. So just to review the epidemiology, the data that has come out of China, this is reporting really low level of prevalence in children. So, for example, in February 22, out of the 72,000 cases that were reported in China, only 2% were in children less than 19. The US data from CDC as of April 6, 2020, children less than 17 represented only 4.74%. So children appear to be less likely infected, less likely than adults. However, and they're more likely to remain asymptomatic or develop only mild symptoms of URI. Therefore, they may be less likely to get tested. So this low percentage could be actually could be higher because children are just not being offered testing. And remember that there was such a shortage of test kits and so on that people who were symptomatic to a certain extent actually early in the epidemic were being tested. So children probably are higher certainly than this percentage. So a little bit about what has been reported in children. Again, coming from Chinese experience, this was published in Pediatrics out of Wuhan, China, between January 16th to February 8th. So out of over 2,000 children that they reported, only actually 731 were lab confirmed. So if we look at those 700 or so children, the median age was 7 years. If you look at the severity of the symptoms, 13% of these children were asymptomatic, 51% were mild, 38% were moderate, and only 5.8% were severe. This compares to approximately 19% of severe cases among adults. So generally, they had milder disease. Even those that had pneumonia, many of them, in majority of them, in fact, had no hypoxia. The median time from illness to onset of diagnosis was 2 days. In that cohort, infants 1 to 5 years of age were more likely to develop severe or critical disease versus older children. And similar, if you look at the CDC MMWR report that I alluded to earlier, similar trends were noted in younger children in the US. But of course, those were earlier reports that came out of US. And as we go on further, I'll be talking to you about some of the more severe manifestations we are seeing in children. And no deaths from this cohort were reported in children under 10 years of age. So the signs of symptoms in this cohort were, majority of these children had fever, many had cough, and a fewer number had shortness of breath, as you can see it on these slides. There was some myalgia and fatigue reported in about 11 to 52%. Less common symptoms were sore throat, headache, productive cough, and hemoptysis. There were children presenting with diarrhea and nausea before the respiratory symptoms. And at that time, this was just being recognized that the GI tract is also one of the organs that seems to be quite affected by this virus. Children did not report loss of smell and taste, which seems to be a very specific feature that's seen in adults. And 80% had mild symptoms, as we said before. These are data from MMWR on April 6 from CDC. Again, reviewing the signs and symptoms among almost 300 children reported in the US less than 18 years of age. And again, we see that fever is present in a good majority of children, followed by cough and shortness of breath. Of course, all of these are lower in children as compared to adults because many children are mildly symptomatic. Myalgia is reported less frequently in children. Sore throat, headache, nausea, vomiting, abdominal pain, and diarrhea, again, in a small number of children were reported. In terms of underlying conditions in children, this is again the data from CDC, taken from only 80 of the children, of those 300 children that were reported. And what they found was that chronic lung disease, including asthma, seemed to be one of the major findings, followed by cardiovascular disease and immunosuppression. Approximately 23% of all children had at least one underlying condition. Of those that were hospitalized, 77% had one or more underlying conditions. Of course, meaning that those that get sick enough to get hospitalized are more likely to have underlying chronic conditions. In terms of laboratory findings, we know that lymphopenia seems to be a major feature that has been noted in adults and also in this series in children. There was some level of thrombocytopenia, which is sort of interesting. It was seen in 36% of the children. And we'll talk about this later as well as we go on and talk about some other things we are seeing in children. Elevated liver enzymes are seen in severe cases. There are elevated biomarkers and inflammatory cytokine levels, CRP, SED rates, ferritin, IL-6, IL-8, and IL-10 levels, and TNF-alpha are found to be elevated in the severe cases, and depression of T-cell lymphocytes. Chest imaging and CT scan, there's bilateral involvement with ground glass appearance and areas of consolidations. And there's some specific appearance called the halo sign that was seen more so in adults than children on CAT scan. Here's a chest x-ray. You can see that hazy bilateral ground glass appearance bilaterally, usually in the lower lobes, you will see that. And the CT scan, again, you're seeing the ground glass opacities bilaterally scattered on CAT scan. And here is that circular halo sign that has been described in adults as well as in some children. So in summary, just talking about what's known is that children appear to be have a less severe disease than adults. Fewer children are hospitalized and have fewer children have history of symptoms of fever, shortness of breath, and cough. So I'm going to talk about New Jersey now a little bit. So this is the graph showing what happened in New Jersey starting from March 8th, going through June 21st. The number of new cases on a daily basis. So New Jersey saw the surge sort of begin around March 23rd, 24th or so, and then peak at about April 17th, April 22nd, and then has gone through a decline. We started to see pediatric cases in New Jersey right around the time as the surge was going up. So our first case was seen on March 29th or March 30th, around that time. And this slide shows you the total number of cases. So our hospital is in central New Jersey in Middlesex County. And during the surge, during this epidemic, our hospital became a regional referral center for our network of hospitals throughout central New Jersey area. So, and here you can see the number of cases. So we are drawing cases from Ocean, Monmouth, Middlesex, Union, Mercer, Somerset, and Hunterdon counties. Because of that, we had a fair number of pediatric COVID-19 cases. So from March 30th, which was our first case, to June 15th, we've seen 45 children. Actually, that number is higher than that. It's approximately 50 have been managed in our system. During what we saw was that during the early weeks, the primary presentation was that of pneumonia or non-specific symptoms of fever without source. So the non-specific fever without source were mostly infants between the ages of 0 to 1 year or 2 years. The majority of the cases we saw were pneumonia cases in the earlier on, and these were usually older children, somewhere in the mean age of approximately 10 or 11 years of age. Subsequently, very soon after that, we started to see children with MISC, so multisystem inflammatory syndrome in children, some of whom have had Kawasaki disease-like features, some had toxic shock-like features, and we've seen, now we've seen more. At that point, as of mid-June, we had seen about 9 such children. And as well as we had some children that presented with inflammatory syndrome associated with ruptured appendicitis. So there were about 7 such children that we saw. So the multisystem inflammatory syndrome is something that was sort of an interesting recognition in children. On April 26th, UK started to report previously healthy children presenting with severe inflammatory syndromes with Kawasaki-like features. Many had cardiac dysfunctions. Most of these children tested positive for current or recent infection. Current meaning with PCR positivity in their nasopharyngeal swabs, recent meaning by antibody, IgG antibody presence, or they had an epidemiological link to a COVID-19 case. The patients had persistent fever with constellation of symptoms, including hypotension, multi-organ involvement, including cardiac, which was the most prominent with very low ejection fractions and cardiac failure, GI symptoms, renal, hematologic, dermatologic, and neurologic symptoms, and markedly elevated inflammatory marker. Usually these children do not have very prominent respiratory symptoms, although some of them did have some infiltrates on chest X-ray. So even though they ended up on oxygen and in ICUs, it was mostly the cardiac manifestation that brought them into the ICU. So in the UK series, they reported 8 such children with 1 death. As I said before, we have seen 9 children and no death in our series. And subsequently in New York City, as of May 18th, there were 147 such cases reported in New York City. At that point, there were 15 in New Jersey. So basically, what we think is going on here is if we look at the course of COVID-19 infection, can divide it into stages. The first stage is the asymptomatic phase, which can be a week or longer. Second is non-severe symptomatic, which is when the children will often have URI symptoms or very mild symptoms. Adults can have more severe symptoms at that point. And then it goes into stage 3 when we get the severe inflammatory syndrome. In children, it's not respiratory, it seems to be more cardiac. And during this hyperinflammatory phase, we see cytokine-induced organ dysfunction. And in MISC cases, it seems to affect the cardiac system more than any others. So, so that's what most of what we are seeing now. More recently are these kids with hyperinflammatory syndrome, although those numbers are going down. So just to touch on treatments, for pediatrics, there are really not very many clinical trials or approved therapeutics as such. We try and encourage people to go on clinical trials as much as possible. We did the antiviral. So in terms of what modalities we have, they're antiviral, the host response modifier, or other types of therapies. In antivirals, hydroxychloroquine was the first one where everybody jumped on the bandwagon and started treating with it due to some in vitro data that was positive in terms of viral suppression. However, we know now that it's questionable if this is useful. We did treat some children with this as well, with or without azithromycin outside of clinical trials. The protease inhibitor for HIV, lopinavir, ritonavir, is approved for children, but is not in any clinical trials in the US. Remdesivir is the antiviral that's the number one go-to drug at this point. We had a clinical trial for this up to age 12 at our institution, and we did use that in a couple of children, although we will probably not have enough data specific to children for this drug as well. Ribavirin has been used in some studies, as well as an antiviral called favipiravir, which is mostly used in outside the US. Host response modifiers, tocilizumab, the IL-6 blockade drug, we have used in children successfully when they present with the cytokine storm type symptoms, as well as anakinra, which is an IL-1 blockade drug. We have also used in some children when they present with the MISC and the inflammatory syndrome. Immunotherapy with convalescent plasma has been available at our institution somewhat midway during this whole pandemic, and we've been able to use that in some children. It's hard to, as well as corticosteroids, it's hard to say what was effective and what was not, because many of these children, when they were sick enough to be in the ICU, basically got a hodgepodge of everything we could give them, which of course is not the ideal way to do things. But some of these kids with cardiac failure were very sick, as well as with respiratory failure. So I'm going to end here. And if there are any questions, I'm happy to answer them. Thank you.